I'm excited about this next segment, discussing administration's investment and achievements in Black maternal health, and to see so many champions with us, our Secretary, Representative Robin Kennedy, Representative Alma Adams, Representative Lauren Underwood, and HRSA Administrator Carol Johnson. Can we put our hands together for this high-power fire team that is with us today? And let me just start off by saying, in this house where you sit, it is an honor to serve this secretary, to see him lead not only as a strategist and expert, but lead with passion and compassion because he understands. And he works hard to make a difference in improving Black maternal health outcomes. And he knows firsthand what we're up against as a nation. It is an honor to serve under this secretary, and I must say, I do not believe there has been a greater champion for improving Black maternal health outcomes than him. So let us now put our hands together and stand for the 25th Secretary of the Department of Health and Human Service and the first Latino to hold the office in the history of the United States, the Honorable Javier Becerra.
Dr. English, what did you eat today? I want some of that. I want some of that. So it is great to see so many of you here. I'm going to depart a bit from my remarks because we've got the real expert, Carol Johnson, who's our administrator at HRSA, who can give you all the work that we're doing, and we want to do more. But I know Carol's got a great story to tell at HRSA of how we are focusing on maternal health, and specifically Black maternal health, actually Black and Native American maternal health, because we know those are the two communities that are hurting most. And then we've got the real champions who made it possible for us to do all this work who are with us. And I have the great pleasure in a moment to introduce to you Congresswoman Kelly, then Congresswoman Adams, and Congresswoman Underwood are going to come up. But for the work that was done by these champions to get real money, because that's what it takes, right? You can't just talk about it. You gotta, if you've got these values in your heart, you better put it in your budget. And that's what they did. That's what they did. And they're going to tell you about those things. But it gives you pride when you actually see Congress, because I used to be there. It is tough to get 218 votes on something like this. You know, you can get to 50, you can get to 120, you can get to 185, you can get to 214, but getting over the hump is always so tough. And that's where you need the folks who are on the ground, that are in the trenches, making sure they get those extra votes. I won't tell you how they got the extra votes, because sometimes it's not pretty, but they got the extra votes. But here's what I think we're telegraphing to you. This is the message I would like to convey to you. Happy Black Maternal Health Month. But don't be happy, it's a week, but don't be happy that it's Happy Maternal Health Week, Black Maternal Health Week, 1 week, 7 days. We got to make it so that it's Happy Black Maternal Health Day, week, month, and 365 a year. That's what we should be talking about. It should be a happy day every day, regardless of the year, when it comes to maternal health. And certainly for the communities that have waited the longest time, it should be a happy time all the time because we're focusing on it. So happy Black Maternal Health Week, but it's time we stop calling it a week and we make it forever, so it's clear it's every year, every year, every year. The other thing that I hope you will see, the thread that runs through everything we're doing right now. And by the way, today there are 46 states that have finally said yes to us giving them money to do postpartum care, not just for 60 days, but for 365 days in the year. Yeah. So that's the happy part. You know what the sad part is? What the heck is going on with the other 4 states? That you have women today who we know in many cases are dying, they or their babies are hurting after 60 days, and they're still waiting. Fortunately, some of them are looking at it. We need to light a fire so they can look a lot faster. But that's what we mean by really focusing. And so the thread that I hope you will see runs through what we're doing, and it's a thread that was woven by the members of Congress, the 3 members of Congress that I mentioned to you today, is what I call equity by design. So that if HHS is going to take one step or spend $1, we stop and say, before you do the calculations on that spent dollar or how you're going to do the motor skill of taking the step, did you put in the design of that plan equity? So you take no step, you spend no dollar unless you have thought of equity as part of how you operate. Not as an afterthought, not just for 1 week, but every single day of the year. At the end of the day, that's going to lift a lot of black moms and a lot of black babies. But you know what? It's going to lift every mom and every baby in America if we do this the right way. And so this isn't about concentrating on just one population or helping one community. It's about helping America. And if we have one baby who gets ill unnecessarily, if we have one mom who goes through deep depression after having that beautiful child because she doesn't get enough help and support, that's one too many. Whether she's black, white, brown, what age, it makes no difference. And so what we have to do is show that we care about every baby and every mom. And we know where in the pockets of America where that's clearly not happening. And so 365, that should be our motto, right? Not 1 week, 365. And by design, everything we do by design. There should be no asking, how did you get that far along and not consider these black moms and black babies that were dying? How could you have spent that much money and not have realized that the women and babies who are suffering and dying are in the black and Native American community more than anywhere else? It's simply saying, gosh, that program you started up, it made sure it covered everyone from day one. That dollar you spent really seemed to be concentrated on the communities that didn't get it before. That's because by design, that's what we do. And so I will close by simply saying this. Thank you for being part of this session today. Please, when you have introduced, and I'm about to do it, so this way she really feels good that I did a great introduction of her. But when you hear introduced the Congresswoman, I hope you will recognize that everything we're doing is because of what they did. Everything we get to do is because of what they fought for. And everything you and I will accomplish in really elevating a mother and her baby in every community, but we understand we got to concentrate right now on a few communities, it will be because they thought of it before we did. All right, so as I get ready to depart, I hope you will have the sort of energy that Dr. English had in making her introduction. And I want to say thank you to Dr. English. I already said to Carol Johnson, our administrator, but Dr. English is the one that helped pull this together. And I want to say to her, I wish I'd eaten what you ate because I would have given you the same shout out as well because you deserve it. This is what she does. It is in her design, and we are very fortunate to have her. But now I need you to get ready to put your hands together because I'm going to introduce to you someone who had the vision, along with her colleagues, to say, we're going to do this, and we're going to make it happen. And when we produce the results, everyone's going to then say, gosh, why didn't you do that earlier by design? Help me welcome the gentlelady from the great state of Illinois and a dear friend, Congresswoman Robin Kelly.
Good morning, everyone. And thank you, Secretary, Dr. English, Carol Johnson. Thank you for all of your work. And I'm honored to be here with my colleagues, Alma Adams and Lauren Underwood, for their tireless support of moms and family. As chair of the Congressional Black Caucus Health Brain Trust, co-chair of the Congressional Caucus on Black Women and Girls, and co-chair of the Bipartisan Maternal Care Caucus, I am so honored to speak with you today. Health, that the topic of Black maternal health is often somber, and it should be. We should treat the crisis of Black maternal mortality with the seriousness it deserves. But I also want us to remember how joyful pregnancy and motherhood should be for Black moms. I'm a mom myself. I have 2 kids and 2 stepchildren and 3 grandchildren. Black families deserve to have happy and exciting experiences growing their families. These milestones shouldn't just be expected, they should be celebrated. The maternal mortality crisis is complex, and our policies to address it must be creative and targeted to solve the many factors contributing to this epidemic. It is unacceptable that Black women are 3 to 4 times more likely to die from pregnancy-related complications than their white counterparts. And of course, that's the average. It depends on where you are because it's higher in the state of Illinois, where I represent. We are the richest country in the world, and yet we still lag behind on many policies that are critical to healthy families. Too often, the healthcare system has failed Black mothers and their families. It is long past time for Congress to take meaningful, comprehensive action to address this crisis. I am proud that I've been able to use my position on the Energy and Commerce Committee to elevate this issue. I'm especially proud to have led the charge to secure a permanent option to extend Medicaid postpartum coverage for a full year. And I was saying it was 45 states, and now the Secretary said 46, so plus D.C. that have now taken that option. And I would love, by the end of this year, for it to be all 50 states. But, as you'll hear from my colleagues, we need to do more. I've introduced the Care for Moms Act this Congress to provide a comprehensive solution to our maternal mortality crisis. This bill will go further than anything Congress has ever done for maternal health. The Care for Moms Act will fund an unprecedented investment to support the maternal care workforce, like doulas, increase access to care, especially in rural and low-income areas, and build out the necessary resources mothers and babies need to thrive. Importantly, we cannot ignore the attacks on abortion care that have been coming from the states and the courts. It is proven that when abortion is less accessible, more women and girls will die, and severe maternal morbidity gets worse. And sadly, too many Black women and girls know firsthand that we are disproportionately impacted by these disparities. I hope that Black Maternal Health Week will bring a renewed commitment by all of our leaders in government and in patient care to support Black moms and ensure that they can live happy and healthy lives. And I want to thank everyone here for your commitment to ending this crisis. And I am so proud to stand with you. And now I'd like to introduce the fabulous colleague I have from the 12th District of North Carolina. I was going to say Alma Adams, but she's absolutely, I'm told, Alma Adams. That's what she's called in the district. So my fabulous colleague, Alma Adams.
And right before she comes, we're asking the members and the secretary to please come. We're going to take a photo op. I know everyone is in a tight time period, and this is probably the only time we have where all of them will be together. So we want to be able to do that. Thank you.
And then just a little tighter, please. Just okay, good. Oh, wonderful. All right, folks, this is great. Very nice. Here we go. 1, 2, 3, and one more, please. 1, 2, 3.
Thank you. I have to run.
Yeah, I'm right here. Thank you. Good morning. I want to thank my fabulous colleague from Illinois, Congresswoman Robin Kelly, for that warm introduction and her kind remarks. And, you know, you've been a long champion for Black maternal health, and I'm proud to stand alongside you, Robin. I know she has to leave. But I do want to thank all of you for being here and thank all of the, not only the participants, but the organizers for putting this together, and of course my very good friend, our Secretary Becerra. Thank you so much. I was bragging in the back that he's been to my district at least twice, and he's going to come again, I know. So Administrator Johnson, thank you as well for hosting this wonderful event. And to all of the distinguished guests, including our mothers, our subject matter experts, our state and local representatives, thank you all for the work that you do for our communities. Service is indeed the rent we pay for living on this earth. Thank you for keeping your rent fully paid up. I do want to bring you greetings from the more than 700,000 citizens of the 12th Congressional District in North Carolina, which includes Mecklenburg and Cabarrus County. It is always a privilege for me to be in the space with folks who are really doing the good work. And it is a privilege to gather with you today under the collective mission to improve the maternal health outcomes of Black women in the United States. And I've got to agree with our secretary. It's got to be 24/7, every day of every month of every year. We must continue to focus on this crisis. As a Black mother and a grandmother, proud grandmother, this issue is very personal to me. And that's why in 2019 I joined the youngest Black woman ever elected to Congress, you'll hear from in a moment, Lauren Underwood, to launch a congressional caucus focused on Black maternal health. And as a mother whose daughter was almost a victim, and my granddaughter who just turned 18 and will be graduating from high school, she was a preemie. She went to her first prom last week, and the second one I think she'll be going to this week. When I think about what could have happened, that I could have lost both of them. And so this caucus is very important to me, and what Congresswoman Underwood and I got together to do was really to raise awareness about this crisis, to educate members of Congress, and then to find meaningful legislative solutions to improve maternal health outcomes. And as the co-founders and co-chairs of the bipartisan Black Maternal Health Caucus, we developed a solution. I know you've heard about it. The solution is the Black Maternal Health Momnibus Act. Love that name, Momnibus. It's about our mommies and our babies. It is a package of 13 bills to comprehensively address all aspects of the maternal mortality crisis with a focus on Black parents using reproductive justice as a guide. Reproductive justice. There's been a lot of talk about the reproductive justice that not only we need, but we need to reclaim. The Momnibus is a bold solution that unequivocally says that Black mamas matter. And so I'm proud to say that we have made a lot of progress, and I'm sure Representative Underwood will speak to some of that. But our first bill from the Momnibus, the Protecting Moms Who Served Act, has already passed and is now law. And we were privileged to be in the White House when the President signed that bill into law. We have also gained historic funding from the White House to address this issue. And so that means a lot to us because it's now from the top down. And so there's still a lot more that we've got to do. But we are keeping hope alive. And we are just delighted to work and to help you as we continue to make sure that our mothers and the babies not only survive, but that they thrive. I am so proud to just be reminded of all of the trees that you're planting. And let me encourage you to continue to do that, because somebody once said that a community can only grow great when old men and old women plant trees under which we know we'll never sit, but we're preserving that shade for those who will follow us. So I am now so very proud to introduce my sister, my Shiro, Congresswoman Lauren Underwood of Illinois. She is my fellow co-chair of our caucus. She's been a true champion of this movement, a great friend, and I am so proud to serve with her. Congresswoman, I yield to you right now.
my gosh, good morning. I'm so excited to be here back at HHS. It's good to be in Humphrey. Thank you so much for the invitation, Mr. Secretary. It's truly an honor, and I'm grateful to all the incredible public servants here at the Department of Health and Human Services for the work that you do day in and day out to protect and care for the American people and assure their health and well-being. And I'm really grateful for this occasion that we could come together to mark Black Maternal Health Week. I'm grateful to share the stage with Secretary Becerra, Administrator Carol Johnson, and my colleagues in Congress, Congresswoman Robin Kelly and Alma Adams. 5 years ago this week, we founded the Black Maternal Health Caucus, and Congresswoman Alma Adams has been my sister and my partner from the very beginning. We're so excited to be able to reach this incredible milestone. When we stood in front of the Capitol that day, I really thought it was just going to be the two of us, not knowing that there was this latent energy around the country, people who were interested in lifting up not only the problem, but working to advance a comprehensive solution. And I'm really grateful that we have had the opportunity to raise our voices together and work in partnership with our 53 founding members to organize around the goals of elevating the Black maternal health crisis on Capitol Hill and advancing policy solutions to improve maternal health outcomes for all moms. Since then, we've grown to become one of the largest bipartisan caucuses on Capitol Hill. And now we're hearing from moms all across the country who are demanding a comprehensive solution to address this maternal health crisis once and for all. Now, while this crisis impacts moms from every community across the country, every demographic, rural, suburban, urban, right? Doesn't matter what racial or ethnic background, what language you speak, this crisis has touched all of us. But we also know that there are tragic disparities that do break along racial lines. Black women do die from pregnancy-related complications at 3 to 4 times the rate of their white counterparts. And it's a disparity that exists no matter the income or education levels. It's just persistent in that way. But with the support of the Black Maternal Health Caucus, I am grateful to be the lead sponsor of the Black Maternal Health Momnibus Act, which is, as Congresswoman Adams said, this comprehensive package of 13 bills designed to address every clinical and non-clinical driver of maternal morbidity, mortality, and disparities across these United States. This legislation is truly designed to solve the crisis, and it's not a Band-Aid. We're talking about a solution. We've been working on this solution for 5 years, and we have made some really good progress. We passed the first Momnibus bill into law, as you heard, the Protecting Moms Who Served Act, and it helps our veterans receive the world-class care that they have earned. And last year, for the first time ever, we unlocked funding for historically Black colleges and universities and minority-serving institutions so that they, yes, can begin to do research, critical life-saving research at these universities across the country. But that's not all. So you all heard some headlines saw some headlines over the last few months talking about shutdown, shutdown, shutdown. Well, we averted a shutdown. And last month, President Biden signed into law the 2024 federal funding package. And in there, we had $100 million to address key Momnibus priorities. And we're excited that our partners here at Health and Human Services are going to begin awarding these dollars to great grantees across the country. Excited about the partnership that lies ahead as we continue to fund these programs. We know we still have a lot of work to do. We know our maternal health crisis is getting worse, not better, right? The data keeps coming out and telling us that we need to keep pushing. We need to demonstrate the bipartisan will that we know exists in order to invest in these solutions and the people and the community organizations that are doing the work with urgency, that are doing the work with excellence, and are doing the work that is necessary to save lives. I believe that this year we have a unique opportunity to get it done. Now more than ever, Congress is realizing that this maternal health crisis impacts the lives of every American. So the time for Congress to pass the Momnibus is now. Let's end this crisis for good. So thank you all so much for your time. I would like to invite my partner in this work, Administrator Carol Johnson from the Health Resources and Services Administration, to the stage. You know, she's been so generous to take my calls and hear our ideas and to brainstorm. And just recently, I was so honored to join Administrator Johnson for the work as HRSA has launched their new National Maternal Health Initiative. Thank you so much, Administrator, for all that you do, and I look forward to continuing our work together. Thank you, everybody.
Hi, friends. Good morning. Thank you so much to our colleagues in the legislature. I mean, it is amazing to have the opportunity to work with Congresswoman Underwood in this role. You know, she used to work here in the Humphrey building in a prior life, and so she knows exactly what it takes to deliver on the commitments and the challenges that we're all working on together. My thanks to the Secretary and Congresswoman Kelly and Congresswoman Adams for their leadership. You know, when we came in the Biden-Harris administration, one of the first things we did was look at the data that showed the United States is among the worst in the developed world when it comes to maternal mortality, and there are unacceptable disparities when it comes to Black women and Indigenous women. And so we set about an agenda to change that. And that agenda is about hope, as everyone has said, but it's also about action. And so the president pulled together all of our leaders from across government. And you all know that the vice president has been a champion of these issues since day one, since her time in the Senate. And so together we wrote the White House blueprint for addressing the maternal mortality crisis. And I hope that you all see your fingerprints on that document, because it's informed by all the work that you have been doing for years. We hope that our initiative and our work in this administration, that you feel your imprint on it, that you know that this is about us putting our wind at your back to be able to achieve what you've known for years are the kinds of things we need to do to change the trajectory of this crisis. And so, as the Secretary pointed out, step one, let's make sure that everyone has Medicaid coverage 12 months postpartum, not just 60 days. Of course, we need to do that. We put the money behind that. Congresswoman Kelly and the caucus put the legislative heft behind that. But everyone in this room, everyone online knows that is necessary but not sufficient. I used to run a Medicaid program. Your Medicaid card is as good as having a high-quality provider that you can access in your community, that speaks your language, looks like you, someone you can trust. That's why we need to invest in the healthcare workforce. That's why this administration, under this president and this secretary, we've had the highest level of healthcare providers in our national loan repayment program, where we pay healthcare providers medical debt in return for them practicing in high-need communities. And as a result, we have more OBs, we have more nurse midwives in high-need communities all across the country. And our loan repayment program always overrepresents the communities of color around this country. That's who we recruit into this program, that's who comes to this program, that's who we're able to help make it possible for them to work in high-need communities. And so there are OBs and nurse midwives, and now we're training more community-based doulas as part of this project as well, to make sure that we can make a real difference on the healthcare workforce. We also have been able to invest in our community health centers. So you know, health centers are all over the country. There's 1,400 of them. They have 15,000 sites. This is where healthcare is provided regardless of people's ability to pay. And this is where we need to be dedicated to early connection to prenatal care. And so we've made new investments thanks to the leadership of Congress and of the women in Congress and to our secretary in getting us the resources to be able to do that. We're connecting community health workers to pregnant women earlier, doulas, really focused on what it takes to help people through the journey of pregnancy. But look, it can't just be about the clinical experience of what happens when you're in prenatal care and delivering. We all know that healthcare happens in the community. We all know that your access to services is completely dependent on your transportation access and food access and childcare support and all the things that make it possible for you to get healthcare. If you're missing hours of work and you have to take 3 buses and you have to find childcare for your kid to get to a prenatal visit, it's going to be a lot harder for you to get to that prenatal visit. That's why we invest in community-based organizations and why we have been leaning in and supporting our Healthy Start initiative, home visiting, which is high-touch, in-home supports from nurses and social workers, and really focused on what it takes to make it easy as possible for pregnant, new moms, interconception care, possible to get the kind of support and services that make it possible to have a healthy pregnancy, healthy delivery, healthy mom. And we know that we don't know everything. And that's why, thanks to the Momnibus team in Congress, we have new resources invested in historically Black colleges and in minority-serving institutions to do the work in the community to test what works, and then for us to be able to bring it to scale. We're so excited about this. Morgan State is the head of this research network, and we're really thrilled about what we know it can deliver for us as we go forward. We also know that rural communities are an area of considerable concern, and I think too often the misperception is, well, Black women are in urban areas. No, Black women are in rural areas too. And as rural hospitals are closing labor and delivery services, we need to make sure that we're doing everything we can to support access to services in rural communities. And that's what we've been able to do with new resources as well, thanks to our team here at HHS and our friends and colleagues in the Black Maternal Health Caucus. We also know that 80% of causes of maternal death are preventable. 80%. And that is about tackling mental health and substance use disorder, cardiovascular disease, hypertension, gestational diabetes. That means we have to have both a clinical focus and a support focus to bring down the stigma around getting help and support for mental health and substance use disorder services. So we have an initiative that we're growing in all states across the country to work in hospitals to make sure that hospitals are trained and prepared if something starts to go wrong. Obstetric hemorrhage. There's too often, the team hasn't drilled in that in a long time, or the checklist isn't available. We need to make sure that it is, and that's what we're doing in integrating that into our birth-friendly hospital strategy. And then when it comes to mental health and substance use disorder, this is an issue where we need to do more holistically across all Americans and more access to care and services. But as importantly, we also need to bring down the stigma and make it easier to access care. That's why we've launched our Maternal Mental Health Hotline, which is a safe, confidential space, 24/7, call or text, talk to a mental health counselor, get the kind of emotional support, and if you need it, referral to care and services. But we have found just amazing conversations happening through these phone calls that give people the support and comfort that they know they need. I think, again, one of the most heartbreaking things for me as we do this work is to, as we travel around the country as part of our new Enhancing Maternal Health initiative, where we're visiting 10 states and really bringing together all of our grantees to talk about what we're doing and what we could do going forward. One of the most heartbreaking things for me is when moms say, I did everything right, and then there was still this bad outcome. Too often, pregnant women feel like this is their responsibility and they should have done one more thing, when in fact it is a failure of all of us. If there's a bad outcome for a mom or a bad outcome for an infant, and we need to take ownership of that and make sure that we're doing everything possible to wrap around pregnant women the support and services that they need. And mental health and substance use disorder is just one of them, but it is a critical one, which is why we're expanding our maternal depression program in states across the country to make it so that your primary care provider, your OB, knows more about mental health, is better trained, has better access to support from perinatal psychiatrists, from others who can help make sure that they can meet your needs immediately, and not that when you're pregnant and you have a mental health need, you get a referral to go see someone in 6 months. Well, that's not particularly helpful to you. We need to change that dynamic, and that's what our initiative is doing. So we're really excited about the work that we have been able to do when it comes to all of these critical risks and indicators, but but for all the work we do inside the clinic walls and all the work we do about improving access to services, just as important is the work we do in community. So we fund the Healthy Start program. We fund the home visiting program. We actually just worked with Congress last year to double the investment in the home visiting program, which means, pregnant women in the community have access to community health workers. They have access to support and services. I mean, sometimes it's, I ran out of diapers today, or I ran out of formula, and someone drives to your house and gets it to you. But often it is making sure that people get support, get transportation to their healthcare visits, that they get help with, okay, now I think I can rent an apartment, but I need help in understanding how to do it. I need help in getting on my own. How do we get tenancy support? How do we help people make sure that their rights are protected as they get into healthy living environments? So we are thinking holistically about social determinants of health so that we get the best possible healthcare outcomes for everyone that we're supporting, because that is our goal. That is, when we say 365, we mean 365. That doesn't just mean the day you have your prenatal visit. It means everything that happens to you in your community. And so if I can, I'd like to just leave you with one ask. And that ask is, if you could help us get the word out about our maternal mental health hotline. The phone number is 833-TLC-MAMA, and it is available 24/7, access to mental health support and counselors. In fact, one of our counselors here in the front row. You could come to our website. We have on our HHS.gov website, we have a red button that takes you right to the prompt for the information on getting to the hotline. Maybe you all could put that on your website. That would be lovely. We also, on our website, you can order our swag. We have a little merch. You can get our posters and our magnets, and if you could get those. Number one, we're working closely with hospitals to get them into hospitals, but we need them. Where we really need them is in libraries and laundromats and community health centers and in your Boys and Girls Club. And so getting the word out and helping us amplify our message about the fact that support is available and we all as a community are here to help get the best possible health outcomes for women, we would really appreciate it. Thank you, everybody.
Wonderful. Thank you, Administrator Johnson. And those resources she mentioned are in your packet, so please do look for those, and of all the presenters today. So I want to just extend that thank you to Administrator Johnson and Secretary Becerra, Representatives Adams, Kelly, and Underwood, and the extraordinary work of the Black Maternal Caucus. So, thank you. My name is Heidi Christensen. I have the pleasure of serving at the Partnership Center for Faith-Based and Neighborhood Partnerships under the leadership of Reverend Dr. Q. English. We are so pleased you are here. And it is my honor to welcome Dr. Charlene Wong, Senior Advisor for Health Strategy, Office of the Director, Centers for Disease Control and Prevention. Why don't you both come up and we'll sit up here. And then also Dr. Cheryl Bellamy, President, Association of Women's Health Obstetrics and Neonatal Nurses. They're going to address these critical maternal health concerns that have been mentioned throughout the morning: intimate partner violence, IPV, substance use disorders, and syphilis. So we'll have Dr. Wong, you'll be speaking first, and we're looking forward to their comments. And again, thank you.
All right, thank you so much. We're so thrilled to be here. Hold on. You know what? I'm not sure if my slides are in there. Okay. You know what, guys? I'm just going to start talking while we find the slides. Okay, so I think it's been wonderful to be here to hear the talks that have preceded, and what I am hoping is that we have slides. How lovely. I know, let's clap for that. So I come from the CDC in public health. We love data in public health. And so we've heard a lot today about the disparities that exist. What I'm going to show you is a few key figures that tell us where are we at, where are we going, as well as what can we all collectively be doing in our systems and our communities as individuals. So first of all, been said so many times today, Black women are disproportionately bearing the burden of pregnancy-related deaths, and this is a true tragedy when our data also show us that 80% of these deaths are preventable. While we know that a number of factors tie into that, and we've been talking about those today, certainly quality of care, right, ties through all of these. We've also heard today about the need for more respectful care. I hope that many of you all saw some of these data that really should be a call to action and the urgency that we need to do things differently, because these data that we collected last year from across the country showed that 1 in 3 Black women reported receiving disrespectful care during pregnancy or and afterwards. And it's not just that they receive disrespectful care during that care. That has so many ramifications on so many things, including most women then not asking questions when they had concerns because they did not feel comfortable asking that question. What is it that we are doing about that at CDC? And I've heard about so much that so many people are doing. I do hope, and maybe by show of hands, who here has heard of our Hear Her campaign? This is about what I've heard already today, lifting up the voices and stories of women, having that message of what are the warning signs that people should be looking for, coming from women who look like them, who have been through similar experiences to them. And so that's some of the work that we're doing. Let me hit through the 3 topics that were mentioned. The first is intimate partner violence. Again, one data figure that shows urgency. We must do something. 50% of women are experiencing some form of intimate partner violence. There are so many kinds. And again, we know that the disproportionate burden is falling upon our communities of color. We all have things that we can do here. I did want to highlight at CDC and in public health, one of the things that we do is we bring together and we say, what do we know that works? And so in this resource, and there's a link here on the slide, it outlines some of the key strategies that states and communities can take and take advantage of what the best available evidence shows works. It's things like, how do we teach from young people through adults what safe and healthy relationship skills are? How is it that we're engaging with influential adults and peers, like men and boys, as allies in prevention of intimate partner violence? How is it we're creating protective environments? And that's in schools and in our workplaces. And in this resource, you don't just see these listed, you see examples of ways that people have really been able to implement these types of programs because we want to prevent this violence, of course, before it ever happens. I also heard Administrator Johnson just mention substance use disorder. We are hugely concerned about this. When you look at the top reason for maternal deaths in this country, mental health is at the top of the list, and about half of those are from substance use. So again, one thing, I also been hearing this word hope. So this figure, I wanted to show a hopeful figure because, again, we know that there are things we can do to improve some of the issues and disparities that we see. So this graph on the left here, let me orient you to it. This is something that our colleagues in Illinois in what's called a perinatal quality collaborative, which actually works very closely with some of the groups that Administrator Johnson just mentioned. They said, we see our data. We have got a substance use disorder problem. We have too many pregnant women who are not getting the treatment that they need. And what they did is they said, we want to put our systems and tools in place so that every woman who's coming through our system, by working with partners and working with communities and linking them to care, is actually getting that treatment. What you can see at the left, which is what before the program started, white women in the orange bars were about twice as likely to be connected to treatment as Black women who are in that blue bar. And as they did this work together over time, you can see that disparity went away. Now, this should be at 100%. It's not at 100% on the very right side either, so there's still more work to do. But just to show, there is hope. There are things that we know work, and it's just about putting it into place and having the resources to put it into place. So what is CDC and broader Health and Human Services doing in this space? One, I talk about these perinatal quality collaboratives. These are folks who are on the ground, know their communities, are working with community organizations, health systems to really think about how do we improve that quality of care. We at CDC also fund data and driving that to action through our program called the Overdose Data to Action Program. And then broadly at HHS, Secretary as well as Administrator Johnson mentioned some of these activities. We have a maternal mental health task force. We have all got to come together. This is a wickedly hard, complex problem. And so we're writing a national strategy right now to address untreated prenatal, perinatal mental health and substance use disorder, as well as the Secretary mentioned our focus on this postpartum space, as did Administrator Johnson. We have all these women who have 12 months of postpartum coverage. I am a primary care provider myself. The women who most need the care that could be provided as part of that coverage are, in most places, the women least likely to still have access to that care, even though it's newly available to them. So what we're very focused on here is how do we get the women who most need these services connected to those services? And we hear from the states we're working with mental health, substance use, top of mind for everyone. And then lastly, got to talk about syphilis. You see these graphs, they look like mountains. So on the left side, we see a huge increase in the number of women of reproductive age, so 15 to 44, who are being diagnosed with syphilis. And guess what happens when that happens when they're pregnant? We then have congenital syphilis. And you can see that purple graph on the right. We have had a 10 times increase in number of cases of congenital syphilis from 2012 to 2022. And what does that mean? I'm a pediatrician. It is tragic. It is horrible to see these babies who have congenital syphilis. They have infant deaths, we have stillbirths, we have incredible morbidity and disability because of congenital syphilis. But again, I want to say that there is hope. We actually have the tools to do the screening and the treatment and the follow-up for congenital syphilis. So a couple things. I want to start with the bottom one. Again, HHS has come together as a whole agency to say we have got to work together to do something. We've got the Syndemic Task Force, which is both about addressing syphilis, but as it turns out, there's overlapping issues with other sexually transmitted infections like HIV. There are overlapping issues with substance use disorder. So this task force is working on how all of those things overlap together. We at CDC have also been releasing new guidance, first ever guidance this year on syphilis lab testing. There have been some drug shortages on treatment. We are also releasing guidance to say, hey, we really need that Bicillin treatment. It needs to be prioritized for pregnant women while we're in this shortage. And then also very exciting, we're in the process of finalizing guidance for what we call DoxyPEP. This is prophylactic doxycycline medication to try to prevent transmission from ever happening in the first place. We're also continuing to fund local jurisdictions to support prevention activities. And let me end my last stat. I want to do a hopeful stat. 64% of potential congenital syphilis cases were averted in 2021 through prenatal screening and prompt treatment. Again, we've got these tools. We just need to make sure women are receiving them. So thank you so much for having me today. The final thing I wanted to say is I've mentioned these three topics. We at CDC, we collect all these data. What are the leading causes of morbidity, mortality? For Black women, cardiovascular disease is the top leading cause, and it is very disproportionate to other groups. And so one thing I did want to announce in this group as well is next month, we are excited that we'll be releasing a new resource that is around hypertension in pregnancy, because this is a major killer cause of morbidity, not just for mom, but also for babies. And so that will be coming out next month, and that is all about how do we get more women so that we know that they have hypertension earlier, and then once we know they have it, get them into control, because that's going to help both their own health and their baby's health. Thank you so much. We look forward to working in partnership with you all moving forward.
Good morning, everyone. I'm Dr. Cheryl Bellamy. I'm the president of, there's my site. I'm the president of AWON, which is the Association of Women's Health, Obstetric and Neonatal Nurses. And to partner with Dr. Wong, which was a wonderful presentation, I have personally been in the world of OB probably for 3 decades, and I hate saying decades, because I'm only 6, I started when I was 16. I've been in this space a very long time, and I absolutely love the space of maternal child health and the work that we're doing and the work that needs to be done. I am 100% on board with that. As an association, just to tell you a little about AWAN, AWAN is a nursing association. It is probably the most prominent association related to maternal and infant health in the U.S. Our focus is on the health and well-being of women and newborns, and certainly built into that is the health and well-being of families, because we know that the testament of a society is related to birth outcomes. So it's important, the discussions that we're having here are so important as a society that we do something, and as many of the speakers have said, we know what to do. We know what the problems are, but we are focused on the action of that. So our mission and our membership's 25,000 members. However, that touches about 380,000 nurses, not only in the United States, but other communities as well. So in the space that we're working in, it's important that we provide the education, and that education is also built on research and training, as well as the information coming from agencies such as the CDC, Health and Human Services, and other agencies, so that we can put the learnings into action on all the patients that we see. So with AWAN, as it relates to intimate partner violence, substance use disorder, and syphilis, we have several different programs that are available. And these are programs that are not only clinician-facing, but they have to be patient and family-facing as well. So intimate partner violence, as Dr. Wong stated, is a major issue not only in the United States, but worldwide as well. So as we think about the needs of programs and how we're going to impart that to the clinicians and asking those questions not only in the OB setting but in the ED settings when patients are presenting, it's important that we are armed with what questions to ask, but also what resources need to be provided to that patient. Congenital syphilis, as Dr. Wong mentioned, is a very huge problem, and I'll talk about some action items on the next slide, but also knowing the facts behind from 2012 to 2022, a 10-fold increase in the number of cases of syphilis, and that can lead to those poor outcomes for moms and babies. And if you're impacting moms and babies, you're impacting certainly the entire family, the community as well. So as an action-oriented society, then that is something that is one of our charges. And then as an association, we also have certainly things related to substance abuse, substance use disorder, and the strategies that are surrounding that as well. And as Dr. Wong mentioned, many of the substance use disorders are linked with mental health as well. So when you are addressing any issues such as that, you have to encompass not only the treatment methodology, but also the mental health needs for that person and that family as well, because it does impact the entire family. And one of the other things I wanted to mention is it all surrounds respectful maternity care and respectful maternity care. And I know I'm speaking to the choir, and don't you love being around your people who understand what you're talking about? Because my colleagues and I often say we are the people we serve. I am a mother. I am a Black mother. I have 2 children by birth, 2 children by love. And it is my goal as a person to assure that my children and your children and our children have safe pregnancies and have safe birth outcomes, and that is my goal. So as a hospital, I work for Henry Ford Hospital in Detroit, Michigan, and Detroit is like in DC, is a very urban setting, and we have a melting pot of patients and families that come to our setting. And in caring for them, we utilize the tools and the learnings and the stories from our patients and families, and we build upon that to produce items that are serving the patients that we need. So related to intimate partner violence, as a clinician, and I said I started at 16 and I've been working in this for 3 decades. I have seen countless, and I've been present for countless births. I also trained as a midwife. So it is always my honor and privilege to be at the bedside in the space of someone giving birth. However, working in with a high-risk population, I have also been present when I needed to, as we say, jump on a mom's chest and start CPR, which is absolutely devastating to know that this person just gave birth and now I am performing CPR. And how does that happen? And what can we do to prevent that? And I've been at the bedside with a mom holding her hand as she was taking her last breath. And it is devastating when you are doing everything you can to bring joy, to bring happiness, to bring that transition from pregnancy to childbirth to then growing with your family. And it is tragic when that happens. So as a nurse working in this space, as it relates to intimate partner violence, we should always ask that question at every interaction. Mom, have you been in a space where you felt that you were pressured, where you hit, where you spit on, where you harmed in any way? Because if you ask those questions, you don't always get that, yes, that was me, because some people may be embarrassed related to that or afraid to say something about that. But we have to build in the normalcy of asking that question, but we also have to back that up with, if that person says yes, then what? So it's up to us to know that the then what is, let me connect you with some services when that happened. And I'll share one story that was probably one of the most tragic ones that we've experienced at my hospital, is a mother who was being abused by her partner, presented to our hospital because her partner, after he abused her, he set the house on fire. However, he put gasoline by all the doors. So there was, and up to the stairs. So there was no way that she could get out of there, nor her children. So she had to toss her children out of the window to her neighbors, and then she jumped from the second floor. And of course she was injured. She survived, but the tragedy in that of her, for herself and her family, is lifelong. So we wrapped ourselves around her, and then we provided those services of compassionate care, connecting her with services as well. Substance use disorder, as Dr. Wong mentioned, from a clinical standpoint, that is something that we see quite frequently in our setting, working with moms as well. So our goal is to then utilize the resources of connecting the mother with services, but also testing to assure that when we are seeing patients, it's not always the patient you think that is using substances. So we can't have bias in our assessing that as well, because we have 5 birthing hospitals, and the substance of choice is different at every hospital. So in Detroit, our hospital, the substance of choice is marijuana. In our most affluent hospital, the substance of choice is prescription drugs. So it looks very different when the person may present, because maybe you don't smell the marijuana, right? But you can, when testing, the impact of it is more severe when you're using other substances as well. So also connecting them with behavioral health services, and also making sure that the staff is trained in compassionate care and follow through as well. And syphilis testing, as Dr. Wong mentioned, in the Metro Detroit area, we have a high prevalence of syphilis, and the driver for us to do testing is based on the data. And the health department will say, because there is a high prevalence, you need to test more often. So we test 3 times during pregnancy: on admission to prenatal care, at 28 weeks of pregnancy, and on admission to the hospital. And if that mother is test positive, because we know, as Dr. Wong said, the impact of a positive mother on that baby and leading possibly to death, neurologic disorders as well, is huge. So our goal is to test frequently and to treat the mother. And we also, in treating the mother, have to be aware that from a national standpoint with medications, there are medication shortages that need to be then directed to the need. So right now, the treatment for syphilis, the medication that is used is being, the primary medication that is used to treat syphilis is being directed to women that are pregnant because of the impact that it has on babies. There are other treatments as well, but it's important that as we look at all of these things that we've been talking about today, intimate partner violence, substance abuse, syphilis, maternal mental health, and all of these things, that we as a nation know the answer. We as a community know the answer. And as one of the speakers says, I'm going to steal her you ever do that? I'm going to steal that phrase. Joy is a birthright. It is a birthright. That is so profound, because I want everyone to experience the joy that I had when I gave birth to my children. I want everyone to be in that moment and to have those memories, because if you have given birth, you know those moments, right? And you can recite those 25 years, 50 years in detail of what happened to you. So my goal is to create an experience, a birth experience, that patient and family wants at all times. So I appreciate the time with you today, and I think we'll have time for questions later. Thank you so much.
Thank you. Thank you, Dr. Wong. Thank you, Dr. Bellamy. Thank you, thank you, thank you. Information is, knowledge is power, right? And we need this education. No one who knew that we'd see an uptick in syphilis among pregnant and postpartum women. Who knew? And so we really need to pay attention to that and think about ways that we can get in front of it. Okay, so now we're going to talk about models that we can replicate. Because while we understand these atrocities, there are models that are working real time in our nation, led by incredible people that I'm so honored to bring up at this time. And we're going to have a conversation. As you heard later on, we're going to have time of interaction and meeting them so that you can think of which model resonates with you that you would love to see replicated within your own community. Again, it's all about keeping hope alive. As long as there is breath, there is hope. Okay, so I will get started in bringing up our panelists. We have, I thought my all staff was going to help Ben bring up the chairs. Yeah, poor Ben. You got it. So I'll tell you who's coming up. How's that? We have Adelaide Appia and Valerie Rochester from Creating Healthier Communities, Kamala Dixon from Moms to Be, the Department of Obstetrics and Gynecology, The Ohio State University, Wexner Medical Center, Meredith Shockley Smith, Executive Director, Cradle Cincinnati, and founder, Queens Village, Jay Wilson, CEO and founder, Melanated Moms. And let me do a proper title for Adelaide Appia. She's the Director of Programs, and Valerie Rochester is the Chief Health Equity Officer at Creating Healthier Communities. Let's give them all a hand as they come. So we're going to start out with just a quick round of introduction. And following that, we'll have Creating Healthier Community to start out with their presentation. But let's first start out with the introductions. Why don't we start from that end?
Hi, everybody. Good morning. My name is Adelaide Appia. I go by Adele. I'm the Director of Programs at CHC, Creating Healthier Communities, and I oversee our programming and grant-making initiatives.
And we're going to be the dynamic duo today. I'm Valerie Rochester. I'm Chief Health Equity Officer at Creating Healthier Communities, and work on building out our health equity framework, which we'll talk a little bit more about, as well as supporting the program development and grant-making initiatives at CHC.
Good morning, everyone. I'm Dr. Camila Dixon. I am an OBGYN at The Ohio State University Wexner Medical Center and the medical director of Moms to Be.
Good morning. My name is Jay Wilson. I'm the founding president and CEO of Melanated Moms, a community center women empowerment organization, a mom profit, not a nonprofit.
I love that. I'm going to write that down and steal it.
So much stealing. I am Dr. Meredith Shockley-Smith, the executive director at Cradle Cincinnati, which is an initiative at Cincinnati Children's Hospital where Queens Village is held, and I am the founder, which focuses on Black women and infant mortality. Great outcomes. I'm excited about the work that Black women are doing in our county.
So great. I can't wait to hear more, and we're going to hear more starting with CHC. So you got the floor.
Thank you. I'm going to start with the genesis of our Black Birthing Initiative, which we are implementing in 3 cities across the country, in Cleveland, in Atlanta, and in Detroit. And then we're also looking at how we can build out some of the efforts in Indianapolis. And when CHC was first presented with the funding opportunity to help focus on Black maternal health issues, we really, along with pretty much everybody else in this room, realized that the healthcare system overall has been failing Black women, but Black mothers and birthing people in particular. And so what we wanted to do with the funding was to look at how we could help improve standards of care for Black women and Black birthing people, and also increase access to what we consider to be wraparound services. Pretty much standard things you would think about, but things that were not always present in the communities in which we were focusing our efforts. And so the work that we do has 4 key approaches that served as the basis for the work, and Adele will talk more about the core elements of the model in particular, but our approach to the work centers on being community-led, community co-created, and community-informed, and that's something that we start every initiative with. We partner in and with communities in order to help bring about needed change in order to improve health outcomes. We also make sure our work is data-informed and data-driven. And Kimberly, earlier, our keynote speaker, referenced that we're done with data. That may be true, but we're not done with how we use data, how we translate data, and how we share data. And that's one of the driving forces of our work also. We also help to uplift not just the scientifically based data, the quantitative data, but we also uplift the lessons learned, the best practices, the lived experiences, the qualitative information that we hear from the communities in which we're working, because that's where the solutions come from. So that's all part of the data-driven aspect. We focus on fidelity. We develop program models, co-create those with communities as well, and these are models that are scalable and replicable and agnostic, so it doesn't matter what the health issue is necessarily or the geographic area. It's an approach that can be applied to any health issue, and there's some flexibility that goes along with that. And then the final piece, as far as our focus approach is concerned, is that we are equity and justice driven. And when I talk about health equity, when we talk about health equity, equity is not equal and it's not fair. It's about what needs to be in place in a community in order for people to live and be well. And so these are the components that kind of shape our work overall, but also led to the development of the Black Birthing Initiative, which is a pilot that we launched just under 3 years ago. The first year was spent developing the pilot itself, the design and the approach, identifying the partners, identifying what the needs were in communities. And then we are in year 2 of implementation of this, and Adele's going to talk more about that.
Yeah, and before I begin talking about our implementation and impact, I need to shout out our grantee implementation partners. We have the honor of working with Black-led community-based organizations across the cities that we are working with, and they've been taking care of their communities for a long time. So we're so grateful to be uplifting their work in this through the Black Birthing Initiative. But our implementation model has 6 components. The first part is screening, and so we screen that Black mama when they walk through our community partners' doors 3 times throughout their journey with the CBO, and we're looking for a change in SDOH needs and in stressors. So we are screening them at baseline, midline, and endline, right? And then we have case management. So every mama has access to a doula, or we call them a birth advocate. As a part of their relationship with the birth advocate, they receive prenatal education, prenatal advocacy, social and group programming, and birth accompaniment. One thing that I want to amplify is that we spent the first year speaking with pregnant and postpartum Black women across the areas that we are serving, and they told us about what they needed to have a positive birth outcome, right, and to experience joy in being pregnant. And those that data is how we develop these components of the model. So I'll touch really quickly on the impacts that we have seen. So we've been able to engage with 310 Black mamas through eligibility screening, and that really amplifies the desire for these needs in our focus areas. We are currently we've enrolled 174 participants. So you might be wondering, if we've engaged 310, how are we at 174? There is eligibility criteria, and for mamas that don't meet our eligibility criteria, we do refer them to other programming in their areas. So our data and analysis has showed us so far that there has been improved patient-provider communication, so mamas are feeling more confident as they're interacting with their patient-provider, and improved mental health resources and reduced stressors, things that we were hoping to see. We've celebrated 39 babies through the BBI program thus far, and we began operating the program a little over a year ago. 70% of our babies have been born at full term, and we believe that there's potential for significant cost savings as a result. There is a data point around preterm births costing about $64,000, so we believe that with our preliminary information, and the fact that our 70% of our babies are being born at full term, there's a potential cost savings of about $2.2 million or just under that. But again, we are still in the pilot phase and validating this information. But I just want to close out the impact with a quote that I did ask if I could share from our grantee partner organization, Healthy Mothers, Healthy Babies Coalition of Georgia. This quote comes from Precious Andrews, the Director of Special Projects and Innovations. And Precious says, "Like many others in my profession, I often grapple with questions of purpose. Recently, during a moment of introspection, one of my program managers forwarded me an email containing a participant's review of Crystal, one of our family support coordinators and doulas. The participant of the BBI program stated, 'I appreciate all of the support you've given me through my pregnancy journey. You've helped my family and me feel more prepared and excited as we embarked on becoming new parents. Despite my labor and delivery not going as planned, I felt confident to handle the curveballs and make informed decisions that supported my newborn baby boy and me. Your knowledge, resources, and the special way you forge relationship with your clients have been pivotal for our journey. Healthy Mothers, Healthy Babies Coalition of Georgia goes above and beyond to support Black families, and I'm so grateful to have found an organization that champions better maternal health outcomes in our communities. You don't just talk the talk, you walk the walk.' Precious goes on to thank Crystal for her support of the family as a doula, and says that moments like these reaffirm why we're dedicated to this work, and receiving this recognition during Black Maternal Health Week is the cherry on top. So this just happened yesterday, y'all. Many thanks to CHC for providing us the opportunity to make a difference, and for their commitment to empowering birth experiences for women of color. Let this serve as a testament to all reading this. We may be unsung heroes, but rest assured our work touches lives and earns praise. The BBI is more than an empirical public health program. The BBI is changing lives, building communities, and strengthening the ecosystem of cares for Black mamas. So thank you all for listening to us today.
Powerful. So we're hearing wraparound services, community-led, co-created, co-informed, adopting best practices and equity and justice-driven. Thank you for sharing. Kamala.
Hi, I'm Camila Dixon. So for Moms to Be, we were started back in 2010 by Dr. Pat Gabby, who's a pediatrician. Because you guys may not know, but unfortunately in Ohio, we have some of the worst infant mortality rates in the country. And there's a huge disparity when we look at that rate, where Black babies die at a rate 3 times that of white babies. I'm an OBGYN, I'm a mom, my son's 10, and I feel really blessed and lucky that I had a wonderful birthing experience, that he's here, and all the joy that I've experienced. So I want that for every single one of our participants. I want that for every single one of my patients, and I feel really lucky that I get to work with our program. We are a multidisciplinary program, which I also love because I get to work with some amazing experts. We have nurses, we have social workers, we have dietitians, we have early childhood educators, we have patient navigators. So we provide wraparound services. The idea is that a mom will enter our program when they're pregnant. So we have moms who literally pee on a stick and then come that afternoon, hey, I'm here, I'm coming to Moms Be. We have moms who are 38 weeks and going to be delivering in the next week or so who come to us, and they continue with us until their baby turns 1. We meet with them weekly in the community. Before COVID, we were active in 8 different sites in Columbus. Of course, COVID hit and we couldn't meet in person, so we transitioned virtually. And that was also really exciting, and I was really, really proud of my team as we were able to make that transition. Since, of course, COVID rates went down and things were healthier in person, we were able to reopen sites, so now we have a hybrid program. So we have moms who come in person, and sometimes they also come virtually. We've had a mom who, we are on a session virtually, and we hear a noise in the background, we're like, what's that? She's like, oh, I'm hooked up to a monitor, I'm in the hospital, I'm in labor. So our participants really feel the community that we've built. As I said, we provide education and support. So we have a bunch of different lessons that we provide weekly, whether it's a lesson about safe sleep, whether it's a lesson about breastfeeding, about meditation, about what to expect when you go to the hospital. We provide that in a very fun way. When they come in person, we have a healthy meal available for them, and they can bring food home to their families. We provide transportation, and we also have childcare too. So really trying to get rid of those barriers that exist and get rid of the stress that is present during pregnancy. As I said, as an OBGYN, I know that I have limited time with my patients in the office. I'm really thankful that we have this program. A lot of my patients participate in this program, and I feel like it's really cool that I get to see them in that realm. They get to see me in that realm, and I get to really know them even deeper and better. Our outcomes are really great, and I'm really proud of our outcomes. We did a large study that was published a couple years ago looking at our outcomes, and we were able to match the moms in our participants to moms in the same zip code who didn't participate, and found that our moms had lower rates of low birth weight babies. And then in our outcomes for the last year, we were able to care for 494 moms last year. And in the scope of our program since 2010, we've cared for more than 4,000. But in the last year, 89% of our moms had full-term babies. 85% had babies of healthy birth weight. 78% were breastfeeding. And 85% completed postpartum visits, which if anyone provides postpartum care, you know that number is really, really high. Usually it's closer to 40, 50%. So I'm so proud of our team and the work that we're done and we're doing, and I feel really, once again, blessed to be able to be part of it.
Okay, it's on you, Jay, and you're so right, Kamala, about the postpartum visits. So that's extraordinary accomplishment to be at 85 there. Jay, it's your turn.
All right, here we go. Good morning, afternoon. So my journey to this work is a little unconventional. Melanated Moms started as a passion project that really was a support system that I was looking for at the time of my life where I needed the most support ever. I was going through a transition from marriage to divorce, and I was becoming a single mom by myself. And I had no idea of what it looked like to ask for the help and the support that I needed in order to still maintain the household that I had with my children, while also being able to sustain our household through my very high demand job. I am a nurse by trade. I'm an LPN. I've been an LPN for 20 years. At the time, I used to work for FQHC in New York City, where we took care of 1/3 of the LGBT community for the city. And I loved my job. I loved everything about it. But my motherhood and the things that became more complex when I became a single solo parent really started to weigh heavy on the way that I can show up at work and also the way I can show up for my children. So I started to seek out support, looked for different mommy groups, and they existed, but they just did not fill the void that I felt was there. It just was something that was missing. So I decided to throw spaghetti at the wall and just decided to make a group myself. So we started on the app called Meetup with 11 moms and our kids, and we just started social events. And it wasn't structured, it wasn't about, you're gonna walk away with this amazing dynamic thing. It was really just about, who are you as a mom? How can I see you? How can I show up for you in the way that I need to show up for myself? And as we kept growing and building, we saw more moms bring other moms and their children and their friends and their aunties and their cousins and their grandchildren. And I started to look around and ask the question, why are you guys coming back? But not in a bad way, right? So what I learned from us doing this is the moms were looking for someone who saw them, who saw the reflection of more than just their racial or ethnic backgrounds, but the other complexities that no one really gets to talk about or ever acknowledge. And I asked them, when you tell other people about melanated moms and you invite them to our events, what is it that you tell them? And I got a very unexpected answer. They're like, you're an advocacy organization. You talk about the things that people don't say out loud. You give us space to feel safe. And then you give us action steps. So you give us the ability to be a resource that we didn't even know that we were looking to find. So for me, I was like, okay, we're going in a different direction. And what I learned is how to lean into that space, not from a space of fear, but a space of faith. And I really had to think about my clinical background of how do I make sure that these moms have the resources that they need, but how do they also look at their health and their wellness outside of just the physical realm. So we started to build out programming based on the feedback and the recommendations of the moms. So the main areas that we focused on was education, advocacy, and entrepreneurship. So with the education piece, we wanted to make sure that our moms were connected to the spaces that can either help them to become more economically independent, they can have better opportunities in their employment, and they saw other people who looked like them who can mentor or provide apprenticeship for them to move forward. We've been able to build and develop amazing partnerships with organizations like HHS.gov and Earth and the March of Dimes and Planned Parenthood, who've pulled us in and really given us the structure that we needed to understand how we're building this plane as we were flying. When we got into our advocacy space, we started to ask those same questions of, how do you get the resources and where do they come from? We're all from different areas all throughout the United States, and we understand that certain resources are statewide, countywide, and citywide, right? But what we don't understand is the connection of policy and how that also influences those resources that are distributed in those different areas. So we started to work with Advocates for Children of New Jersey and asked the question throughout the state to different parents and caregivers. What emerged from that is our training program, Find Your Roar. And I'm so excited to share, in the last 3 years, we were able to publish this as a workbook. We've also been able to train more than 3,000 people, not just nationally, but internationally, on becoming their own advocates for themselves, their children, and the communities that they serve. It's been amazing just to see how much has come from just that genuine conversation of, how can I check in with you? How can I be the resource that you need? How can I help you see what it is that you see in me and yourself? And then last but definitely not least is our entrepreneurship. So giving that space to moms to know that their barriers are not, or the barriers that they have are not limited by their parenthood or the choices that people say that they have. So we developed a program called Birthing My Business, where we teach moms how to create sustainable models within their ideas that they have in their head and help them bring it to fruition. So they're learning how to become nonprofits, they're learning how to become social entrepreneurs like I am. They are also learning how to write grants and how to be in spaces like this to use their voice and ask for the support and funding, because you gotta pay us, to do the work that they need to sustain themselves and their children. And the last piece, and I promise I'll stop talking, we're also creating legacy. So for me, I am a mom. My girls are 15 and 12. They're both bigger than I am. But they remind me all the time, Mom, you can't have melanated moms without your melanated kids. And I'm like, you know what, you're right. But my journey to being their mom was not easy. I'm a 4-time survivor of preeclampsia. I am also a stillbirth mom. And I had no idea that any of those things would influence the work and the purpose behind my company. But I'm so grateful and so excited to be here and be a part of this and to see the change constantly show up in all of the work that we do and the moms and families that we support. Thank you.
Thank you, Jay, and thank you for the work that you do. Again, while you're there, I want your wheels to be turning on what replication looks like, wheels to be turning on just sharing ideas with one another. This is what this is all about. Again, last but not least, we have Dr. Meredith Smith.
I'll start with Cradle Cincinnati and its inception, which was in 2013. In 2013, we had the second highest infant mortality rate in the country of a county our size, which is wild because we have Research One institutions, currently the #1 children's hospital. And so you ask the question, how was this happening in your area? And so I just need to shout out the federal government and our Healthy Start grant. Thank you very much. That is where we started, and we saw our numbers decline, which was a beautiful thing. But as we all know in this room, it was a stubborn Black infant mortality rate. And so we were really focused on how do we support Black moms and babies. These nods and smiles in the front, I just want to say thank you. It's a beautiful, beautiful thing. So about 6 years ago, I was a professor of Black studies and women's and gender studies, and and I also had family dinner in my house once a week. I invited whoever wanted to come over because at the time I had children, and I'm like, we got to do this together. It takes a village, and that's just what it is. And so somebody who was coming to family dinner at my house was also working at Cradle Cincinnati and said, we have a Black infant mortality problem, and we need to figure out how to fix it by asking Black folks. So can you come and do some sort of community dinner or something to kind of activate the work? And I'm like, I know Black women, this is what I do, this is how I get paid, I am a Black woman, let's go. So I get to Children's Hospital, I'm working at Cradle Cincinnati, and they're like, racism, we're gonna tackle racism. I'm like, great, what is the paycheck on that? Because if I win, I'm gonna need my bank account to show it, I am not yet winning, just for the record, my bank account does not show it, but the improved marked difference that we are having in Cincinnati because we have chosen to center Black women, their thoughts and interventions, and doing what they say, which sounds really simple, but it's very challenging for a lot of folks to certainly ask. But then also, once you ask, listening is becoming much more popular. The listening circles of $50 gift cards, $25 gift cards, of this, of that. It's a beautiful thing, but can be more harm than good if you are not ready to do what they are asking of you. And so that is the Queens Village work and why I sit here. But it is a product of the work that people are doing all across Hamilton County, where we have more than 10,000 births and 4,500 of them are Black. I also want to shout you out on the data comment. We are data-driven. It is beautiful to be able to respond to data. And so our work is a collective impact, and our data comes from the health department. So I'll also shout out our county and city health department for giving us almost real-time data. So when we come back around, we're going to talk about what is the impact and what wins do you have. And I'm really excited to share that, unless we're going the opposite direction.
Why don't we go right into that space right now?
Sure.
The impact and the wins. And also, I know you've done work with hospitals where you've done evaluations, et cetera, et cetera. Why don't you touch on that a little bit while you segue into some of the impact and the wins?
Sure. So I'll go back to the Queens Village work, which again is really focused on Black women and what they want. 2 systems change wins, and then I'll get into the infant mortality wins. The first one is the Queens Village is born of community advisory boards. The first one in my house over dinner moved out into some community spaces where infant mortality was high, so it's sort of a place-based reality. Black women who say yes, we pay them for their expertise, they listen around in their communities, and then we do what we want them to do. The Ohio Department of Health said, ooh, these are Black women who really have power and can think about how we should spend our dollars. So all of the maternal and child health dollars are now written, their requests to the Queens Village Advisory Boards. They then dictate where those dollars go. A beautiful thing about that co-power is when I walk in to get care, and you know that the possibility is that I am saying yay or nay to your being paid, the way you treat me changes. And so that's a systems change that came from the Queens. Yeah, it was extremely celebratory. It still continues. This happened. We're on our third time now, so it wasn't the first time. It's kept going, which I appreciate the sustainability of that. Secondly, another huge system change. Of course, as we sit in this space, every national headline, every local headline is reading Black babies are dying, Black moms are dying, and our queens were like, "What are you doing at the hospital systems?" Because whatever it is, we don't know. And so what we want, and we've heard on this table, on this stage already today, is transparency, vulnerability, and accountability. So we went to the hospitals and said, we're going to need that data, and we're going to want to have to show our patients and clients and families, birthing folks, the data. And of course they said, exactly. And so then we just drove with the idea of we all want the same thing, and we can't get there if we can't be honest with each other. And I will just say, through 3 years of hard work, wonderful, amazing, talented people, we have DUAs, and all 4 hospital systems in Hamilton County said yes. The DUA, data use agreement. So they are sharing all of their data around mom, mostly Joint Commission work, around the way baby is treated at birth, social determinants of health and the way that they are supporting those barriers, and then also human resources. So do the people who are serving you look like you from the top to the bottom? Are they being paid well? Those are reflections on how they care for folks. You're underpaid, you're salty, period. And so how do you work on that? We badge them on that, mamacertified.org, mamacertified.org. You can look at that badging, all of those data points that we are collecting. And then there are community advisory boards in hospitals called hospital advisory boards of Queens who help you look at your data, analyze what needs to change, and then hold you accountable to that change. That is systems change. So I appreciate the work that's happening. I cannot own that, for the record. It is the Queens in our county who said, can this happen? Then a host of brilliant minds who came to the table for 3 years, and then leaders who would typically just say no, who said yes, and that is change, which we are excited about, which led to the lowest infant mortality rate Hamilton County has ever seen. Yes, it's celebratory. For data people, that means we are 3 times from the standard deviation of the mean, which is a beautiful thing, clearly creating change. For the rest of us, we are below the national average, we are below the state average, and in Ohio, we are working very, very hard because we have horrible outcomes. And so the Cincinnati work is a beautiful thing. And I'm excited to be here to talk about that. Also, if you are like, how does one create this in all of its pieces of the puzzle? Policy work is happening under Cradle, direct service is happening thanks to Healthy Start, the activation of Queens Village, and fundraising out the wazoo. Thank you very much for all of those who give. Trust-based philanthropy, shouting out BI3, data collection, et cetera. All of that collective impact, working on what was called a wicked problem. Thank you, Dr. Wong, who said that. We are writing a book called Wicked Problems. It will come out, and we will happily talk to you about how do you collectively do this and have this sort of impact, driving with data and making it work in your space.
Wow. Can someone talk about this type of work for our audience and those that are online? You know, by the way, I think we had like about 1,000, I don't know how many we got online between the in-house and online. But tell me, how this can be replicated when we think of rural communities, right? Because we know we talk about, you know, the transportation issue, all of the challenges they have in rural. Can we say something about your work in rural communities that has worked, that can be helpful to our listening audience?
Okay. Well, so through the BBI, I think one of the biggest things we've learned is a community champion. So we have another initiative that does focus on rural communities. And the first thing that we did, is a listening session, is a conversation with those community folks. No community is monolithic. And us here at CHC, we're not from every community, right? And so I think the first person is the connector, the champion within the community to identify what those true problems are. And then once we hear that information, making sure that the community remains a part of your programming model, and for us, of our grant-making model, right? So one of our programs has a community advisory council or community advisory board, or community action lab is one of the other opportunities that we use as well to make sure that the program remains community informed. So that's one of our approaches to working in rural areas.
And I just want to add to that, another part is we fund collaboratives. So it's more than one organization that is supported. And because it takes multiple sectors, different approaches, different folks in communities in order to come together. So that funding collaborative is also key to looking at what resources need to be invested in a community and looking at it as investments. We're not saving anybody. We're not looking at coming in and taking over. It's a matter of partnering with and identifying where the needs are, regardless of whether it's rural or more metropolitan areas, looking at who's doing the work already and building on what has been proven to work in that particular community. There are a lot of what are called homegrown models. I really don't like that term at all. But the homegrown interventions, as they're called, that are successful, but nobody knows about them. So it's finding those things that work and building on and helping to enhance those, working in partnership with the groups that are actually doing the work.
Yeah, I'd love to add to that. So one of the wonderful things about Melanated Moms, we started in the state of New Jersey. It's a big little state. If anyone has ever been there, it's pretty awesome. But the great thing about New Jersey is it is so diverse depending on which part of New Jersey that you are in. And we got the amazing opportunity to actually do some coalition building. And we were granted a planning grant to really learn how to pull out those voices of Black and brown families all throughout the state and really see where those diverse spaces are and talk about what resources are there and what it looks like in the suburban places and the urban places as well as the rural areas. So our coalition is called the Coalition of Change for New Jersey. We currently have about 31 members, and we broke the state up into 5 different regions, and we also included 2 additional regions for New York City as well as Philadelphia, because we know that people not only will cross counties to receive resources in New Jersey, but they'll actually go into those 2 metropolitan states to be able to receive different resources. Really great example in my career as a nurse. I did pediatric home care, and I will have so many patients who lived in Newark, New Jersey, which is northern, but they will go all the way down to CHOP, all the way to Philadelphia, in order to get specialty and complex care. So I wanted to make sure that we included that in what those resources look like, and then also outline those barriers of if this patient or this person lives in these areas where transportation is few or resources are scarce because they literally don't know that they are there. We're going to be the connector. And our final thing is to create a resource guide so that it is completely accessible and they know how to get to the resources that they need.
Great. I think the other thing is, sorry.
No, please, go ahead.
So I think the other thing to really focus on is really reflecting on the value of technology. I think we saw that as we transitioned in COVID. Our program started in a church, right? We work with community churches, we work with community health centers, but then when everything was shut down, we physically couldn't be in person, we were online, and we've continued that. And I think especially when we think of a model that would work in a rural space, this is one that can definitely do that. We have sessions on Teams and people can sign on. We do also know just from background research that we did that most of our moms do have access to a smartphone. So you don't necessarily have to have a computer at home to be able to access the education and support that we provide. We also do provide incentives for our lessons, and we've found that we can do Amazon gift cards, so we can do that virtually as well. So there are many different mechanisms that we can use to use the technology out there to serve people who need to be served.
I will say I love a theory that you can look up. ABCD, asset-based community development. as the Queens Village work began to spread, we are now across the country, the first thing we do is go in and look and see who are your people who are already doing good things, who may be overlooked, who are the folks who may not be plugged into any organization, but who have complete respect of the community that you need to know, and how do you honor them. So if you're moving into how do I start, I would suggest ABCD, asset-based community development.
Thank you. With that, we do have a model that has been replicated, and we're going to ask, and it's been replicated through a faith-based entity that's partnering with a community-based organization, namely NAACP. So for the next few minutes, I'm going to ask Dr. Michael Bashethi to come and share how he has replicated the model in Memphis, Tennessee, and how they're spreading the model, which is Moms to Be, and the results that they have had on what he's called the Zip Code Project. Give him a hand as he comes.
Do I have a clicker? Oh. Thank you, Dr. English, and to the panel. If I heard it right, whatever the question, the answer is the community. Let me share with you one model that can be replicated across the community. Vicki, will you stand up? This is Vicki Terry, Executive Director of the Memphis branch of the NAACP. 100 weeks ago today, literally at this very hour, I met Vicki for the very first time as part of a delegation from the Church of Jesus Christ of Latter-day Saints, who had a simple assignment. Our assignment was to go to Memphis and ask Vicki a question, and the question we asked was, could we deploy resources of the Church of Jesus Christ to bless the community that you serve? And here's what she said. She said, it disturbs me that we are sitting in a zip code that has one of the highest infant mortality rates in the country. This tall man to the left of Vicki in this picture was my boss. His name is Elder Matthew Holland. When we left that meeting and got into the car, he looked at me and he says, well, you're a doctor. Figure it out. And of course, he didn't want to hear anything about the fact that I knew nothing about pediatrics, nothing about maternal health care, nothing about any of that. He just said, figure it out. And so I started going to work. And here's what I learned. I learned all about racial disparity, things that I had not known. I learned that for decades this has been a problem, and hundreds of articles I saw, very few good results. And then I stumbled across this, quite providentially, I think. This is the Ohio State work led by Dr. Patricia Gabby's team. I about fell off my chair. I called Dr. Gabby. She picked up the phone, very quickly embraced our idea of replicating in Memphis what she had done in Weenland Park, Ohio. And not only did she say that she would mentor me and us, but she said, we'll give you our program, we'll give you our policies, our procedures, everything, and you can duplicate Moms to Be in Memphis. The only thing you can't do is have the name. And so I went back immediately to Vicki, back to Memphis, back to zip code 38126, and said, we can do this. And so I said, Vicki, help us. Let's put together a coalition. And so starting with the church and the Memphis branch, we invited the Public Health Authority, we invited all of the local hospitals, we invited philanthropic potential supporters to come to the table and help us. And we launched My Baby for Me, Memphis. Now, the one thing we couldn't do, Dr. Dixon, that you can do at Ohio State, is we're not an academic medical center. But in our church, we have tens of thousands of retired healthcare professionals, many of whom are willing to drop what they're doing when they receive a call to volunteer. At the end of that table are the Archibalds. We call them Brother and Sister Archibald. They left the retirement in Oregon, moved to Memphis, have been there for 18 months. They are experts in maternal and pediatric care and have presided on the implementation of what is essentially the Moms to Be program in Memphis. What have they done? Over the past year, we've treated 30 individual, unique mothers. We've had over 1,000 interactions with them, and what we do is we teach them how to be safe in pregnancy and how to care for that baby for the first year of life. We provide gap support, the social determinants of outcome. If they don't have transportation, we provide it. If they don't have food, we give it. If they don't have groceries, we give them a grocery bag at every meeting. We basically follow the Moms to Be model. We have had from those 30 moms 20 deliveries this year. We have had not one, in a very high-risk population, by the way, we have had not one low birth weight and not one premature baby to date. The one thing that they've done also, and that we've learned as much as anything, it's not just dollars, it's not just filling the gaps, it's love. The Archibalds love the women they care for, and the women love the Archibalds, and Vicki loves and knows every mother. In fact, we were with her at dinner last night, and 2 mothers called her just in 15 minutes while she's away. Let me share with you an example of what happens. Gwendolyn is a 20-year-old nulliparous woman. She shows up at 22 weeks in the first week of January 2023. She develops an affinity for the program. 2 weeks later, January 15th, she calls Sister Archibald. She says, I have a backache that I've never experienced before. My mom says, your back always hurts when you're pregnant, but this doesn't feel right to me. Sister Archibald talks to her, realizes she's in premature labor, physically takes her to Regional 1 Medical Center. Labor is stopped. 15 weeks later, there is 6-pound, 3-ounce Kamari Johnson, our first My Baby for Me baby, very, very healthy. Now, let me conclude with a thought. The great author and poet, biographer Carl Sandburg once said, a baby is God's opinion that life should continue. We believe that life should continue. Here is Kamari on his 7-month anniversary at our Christmas party with his best friend. And I think what I would like to do to take away from this is that a church and a civil rights organization can partner in a community to bless a community like this. It would be my hope, it would be my prayer even, that we could come together in communities all across this country to give every Gwendolyn and every Kamari the chance at a happy, healthy pregnancy, happy, healthy birth, and happy, healthy life. Thank you so much.
And I did hear, as a result of your efforts that we have now, your state has continued to fund your initiative, which is absolutely fantastic.
So
NAACP, come back up, because I need to close out. I need to close out this panel, but I just wanted him to just mention that one statement.
On April 1st, we were awarded $790,000 in funding by the state of Tennessee to continue My Baby for Me. Secondly, on February 12th of this year, we launched our second implementation of My Baby for Me in Nashville, Tennessee, and we hope to have another implementation in New Orleans, Louisiana, early this summer. And there's no reason it can't go elsewhere.
Thank you so much. Y'all can stay up here because we're about to close out. And by the way, the model he's talking about is what Kamala was sharing about. She is representing Moms to Be. So these models are replicable. I just want to just say this has been so powerful. And I'm just going to recap real quick. When I was thinking about the training of the 5,000 people in self-advocacy, working with the Mom Profit, and the lowest infant mortality rate here as a result of joint efforts. It does take a village. It has to be community grown. advocacy, education, entrepreneurship. And then you heard from the Earth app creator, who was absolutely powerful in being able to use that as a tool for data collection, wraparound services, ABCD, community-led, co-created, co-informed, data-informed, and data-driven. There was so much information given here. There is no reason why we can't think of ways to collaborate, think of ways to replicate these amazing models, and touching 310 Black mamas. And thank you for everybody here that is keeping hope alive. I have so many more notes. The 85% postpartum, visits, and the amazing work of now having the greatest stats as you have seen in Cincinnati in history. This is amazing. This is amazing in history. And so to that end, I feel like next time I need to make it a whole day. So the next we have lunch, and then at the end of that lunch, we'll just sit here and just keep partnering and keep talking and keep networking. And I want to do this quarterly, just amplifying best models and practices, because you know what? It's everything else is being amplified. Deaths are being amplified. Morbidity is being amplified. Let's now look at the models that can address these things effectively. So let's put our hands together for this panel for keeping hope alive. Thank you. Let's network.
Produced by the U.S. Department of Health and Human Services.